Good afternoon. My name is Ramez Aziz, and my colleague John Stewart, who's a nurse consultant in our service, will very briefly talk to you about eating disorders in young people. I was going to cover definitions, prevalence, consequences, and comorbidities. Our services, assessments and management in the primary care, and John was going to cover the treatments for purely technical reasons.
I have to do a run basically, so we might have to do it a little bit backwards.
So John's going to start with the treatment, and then we'll cover the other topics.
So there's probably a few assumptions that we have to make while trying to find this, and that we go through the diagnostic criteria of anorexia nervosa and binge eating disorder and all that kind of stuff, but we're going to have to go to the end and then start at the beginning again, just to confuse everyone. So I guess in 2015 there was this idea that early interventions and getting an eating disorder earlier helped with outcomes. And so there was a lot of money to transform CAMHS eating disorder services nationally. And that kind of just about came in line with the NICE guidance, which basically outlined how the interventions that worked. And predominantly, unlike quite a lot of other mental health conditions, the primary frontline evidence-based treatment is a family-based approach. And so what that basically is it makes the assumption that a young person with an eating disorder cannot make sensible decisions about their eating. So, is that loud?
Yeah.
I've got a loud voice, so can I just speak?
Yeah, just talk.
Cool. Do you want to have that? So it basically means that people with the...
It's fine. Just yeah, go with that one. That one's not so good.
Yeah.
Go with that one.
Is that all right?
Yeah.
Okay. So basically, a family-based intervention is one where the domain at the back. Can you hear? Yeah. It's one where the young people cannot take responsibility of their eating. So the treatment is that the parents take responsibility. So that means that they're in charge of the meal planning, they're in charge of the supervision, they're in charge of everything to do with the eating of the young person. It's broken up into 3 phases. So the first phase is entire responsibility to parents. Second phase is slowly giving responsibility back to the young person. And the third phase is sort of ironing over the cracks or paving over the cracks, basically the impact of having an eating disorder and challenging those. So there's less sort of long-term impact. Obviously, we medically review and monitor. Part of the transformation funding was to get some money for paediatricians to help us with this sort of endocrinological and sort of developmental aspect of eating disorders in adolescents. Here we also have a crisis team, so that's to do home meal support, but how we want to move things forward is we want the crisis team to basically sort of mirror that FBT model, so that family-based intervention where the people will go into the home and help the parents feed the children in situ. So that's hopefully where we're going to move to, not just meal support. Nutritional support, we put dietitians, and I guess the balance that we find ourselves in quite a lot of what is nutritionally appropriate versus what is psychologically plausible. And that's kind of the balance that we always find ourselves in. So, I've just said that all of the intervention is the idea that the family take responsibility of the eating, but obviously, if you have a 10-year-old, that's quite viable. But if you have a 17-and-a-half-year-old, that doesn't quite work so well. So a second-line intervention is CBTE. This is an adult model as well. So CBTE is frontline treatment in adults, and it's the second-line treatment in adolescents. That can't really run alongside family-based interventions because the domains of control are completely different. In one, you have the domain of control with the parents. In the other one, you have the domain of control with the young people. So when people say, oh, shall I have a private therapist to help me out with this, it doesn't really work very well because they can actually have conflicting advice. One of them is taking responsibility, but the other one is listen to your parents. There's multi-family treatment, which is kind of like where lots of families go around and have a supportive meal all together. So, and this is AF, so this is adolescent-focused therapy. It's sort of the third line. There's not really much. It was when they were delivering FBT and they were doing the large randomized controlled trials. It was like the second arm of it. Basically, if your eating disorder examination score is lower, perhaps you would be better with adolescent-focused therapy, but it's certainly under cognitive behavioural therapy. Parents groups. So having a child with an eating disorder is really, really, really hard. It is, I feel slightly guilty as an eating disorders nurse because I go, oh, by the way, you're going to do this family-based treatment. It's going to be absolutely horrific. See you in a week. You know, and the reality is that feeding someone that doesn't want to be fed and navigating the escalating control battles that are sort of inevitable is really, really tricky. A carers workshop, again, this is sort of more about speaking for the carers for these complex patients and how to look after them. And inpatient admissions, there isn't a great outcomes for inpatient admissions, but obviously not, because the most severe people will go into inpatient admissions. But the general consensus is that if you can keep people in the community, they get less wedded to their anorexic identity. They don't come into contact with as many people with eating disorders, and sort of that way of coping and controlling. It doesn't quite get ingrained in the same way. All of these kind of make sense. Like, I don't think there's many illnesses that this wouldn't be the case. So early symptom change predicts good outcomes. So what that means is the quicker the referral gets to us, technically the better the outcome. So, so if we had one take-home message, just send in a referral. If you think that someone's losing weight for psychological reasons, just plug it in, because that will greatly increase the chances of them getting better. And in FBT, a younger age, generally FBT works a bit better because you have more autonomy as you get older, and you tell your parents to shut up a bit more. Whereas when you've got sort of an 11-year-old, a 12-year-old, generally they're still looked after in quite a considerable way. There's still sort of, mum still feeds them at that age. Shorter duration, so like all illness. Less severe weight deficit. So there's also the idea of what happens to your brain when it's starved, and sort of the rigidity, but you go into that a little bit, don't you? So, so the larger the weight deficit, the more anorexic someone becomes, the more rigid they get. There was sort of the Minnesota starvation trials where they basically, it's a bit of rubbish research, but about in the 50s, basically what they did is they got loads of conscientious objectors and starved them. You couldn't get it for ethics now, but it sort of suggested that if you get perfectly healthy men and you starve them, they get lower mood, they get self-harm, they get rigid thinking, they get obsessed about food, they start talking relentlessly about food, and so just the nature of being starved kind of makes you think more about food. But you probably notice that if you go for like 4 hours without eating, you start getting obsessed about food. And if your eating disorder is less severe, you get better quicker. Well, that just makes a lot of sense. And motivation to change. Now, this is probably the one that's hardest to define, because if you ask someone if they want to get rid of their eating disorder, quite a lot of them would say yes. Some would say no and would say that they have more insight into the condition and what it does for them. But quite a lot of people would just say, yeah, I want to get rid of it. But actually, you have to decide to get better from an eating disorder at breakfast, at snack, at lunch, at snack, at dinner. It is really, really tricky. So just someone saying, yeah, I want to get better, that doesn't really, that might not be the same when you've had 4 really bad days eating constantly. and no comorbidities. So I just went to Autism and Eating Disorders conference last week, and there's been 3 research studies, and on those 3 research studies, none of the research methods are that fantastic. They're all retrospective, and they all don't take into consideration the starved brain and all that kind of stuff. But all of them came to roughly the same conclusion, that about 20% of people that are diagnosed with anorexia nervosa could potentially have autism. And then if you're depressed, obviously the thing that really gets people better from eating disorders is a life that's better than an eating disorder. If you're depressed, having an eating disorder is better than a life without it, and so so it's harder to treat. And the same with anxiety, the same with lots of comorbidities. And in eating disorders, it's sort of a service of comorbidities. So actually, quite a large amount of the people we look after have comorbidities, and how we and we're commissioned to treat comorbidities as well. So, is that all of it?
Yeah.
Cool. Sorry about that. I'm off. Catch you later. Cheers.
Right. So we've done the treatment bit. So I hope you can hear me now. I'm just going to quickly run through the rest. And we're supposed to be joined by a service user as well, but unfortunately she couldn't make it. But she did send a slide with a clip just from a service user perspective. So we'll do that at the end. So eating disorders. There's quite a few of them. The main 2 are anorexia nervosa and bulimia nervosa. Anorexia criteria differ if you read different classifications and if you read different versions of them. But generally speaking, it's loss of weight, more than 15%, or failure to gain weight, attempts to lose weight, fear of weight gain, body image or distortion or over-concern with weight and shape, and hormonal dysfunctions. The DSM-5 has broadened the diagnostic criteria slightly, and I think that they introduced atypical anorexia nervosa as well, which is very helpful because we'd rather treat even if there isn't weight loss, so that new diagnoses help a lot. Bulimia nervosa is characterized by binge eating, purging through different methods, and over-concern with weight and shape as well. And there's also the atypical anorexia nervosa, or there's the eating disorders not otherwise specified, or eating other specified food and eating disorders. They are serious problems, and they sort of are either in between both main groups, or just short of meeting the criteria of either, but there's still serious eating problems nonetheless. So epidemiology, again, will vary depending on what you read, but generally speaking, for anorexia nervosa it is around 0.3% cross-sectional, and for bulimia nervosa it's almost 1%, and the cross-section of adolescents, according to a study by Swanson. The minority of those who receive treatment, there is a strong correlation, of course, with other psychiatric disorders, very strong comorbidities. The incidence of eating disorders increased over the past few years in the 15 to 19 groups, and all eating disorders show increased mortality as well. So we're getting more eating disorders, and it's getting more serious. The lifetime prevalence among 19-year-olds in a Dutch study was 5.7% using the new DSM-5 criteria. Disorder eating behaviors and attitudes were 13%. Half of all cases of the adult eating disorders cases start in young people, start below the age of 18, and generally speaking, dieting for any reason increases the risk of developing eating disorder 8 times. So again, more numbers, and if you, like me, not very keen on retaining all the numbers under the sun, I think it's enough to say that eating disorders have the highest mortality rate of any psychiatric illnesses. According to the Swedish registry, 6 times increase compared to the general population. So quite serious. There are other causes of problems with eating. So it could be organic, could be psychological. So things like endocrine problems, GIT problems, malignancies. There's selective restricting eating that we see a lot in people with ASD, things like textures, food, and foods not touching, and they create all these rules, very rigid rules that end up in them having a very small repertoire of food to eat. And of course, psychological reasons like depression and anxiety can cause loss of appetite, but these are not eating disorders as such. Comorbidities like depression, self-harm, alcohol, drug abuse, anxiety, OCD, and ASD are quite prevalent in eating disorders. Anorexia does affect all your systems. If you're starved, nothing's going to work or function properly. It is a mental illness that quite often present with physical presentation, more or less. So it affects, as I said, all your tissues, but it also has strong psychological consequences and social and educational consequences as well. People with anorexia become very rigid in their thinking, generally speaking, but also the anorexic cognitions, which are things like body dysmorphia, things like always thinking that they're eating a lot more than they actually are, or that they're bigger than everybody else, or the portions of food are bigger than anything else, become quite hard to shift. They become oversensitive to criticism, they have changes of mood, and they're always preoccupied with food, funny enough. They start to isolate and become less interested in people, less interested in socializing, less interested in talking in general. They have very low self-esteem and self-image. And they tend to have a blasé kind of attitude towards risk. They tend to have, they deny the seriousness of the illness, no matter how many times you go over it, and they start to take risks with not eating for days or things like that. Their family dynamics start to get impacted, their functioning at school start to be affected, and the wards start to get smaller and smaller. So there are several factors that maintain that cycle. So and you can see that there are quite a few feedback loops that go on. So it's not easy to break out of. John talked about the 2015 funding change and how that affected, how that helped our services enormously. So now we have the capacity to see people within 4 weeks for routine referrals. So if you see someone, think they have an illness, and you're referring to us for a routine referral, we see them within 4 weeks, and we see them within 1 week if the referral is urgent. Emergency referrals within 24 hours are seen by pediatricians because of the nature of the treatment that they will need if they are in that position. So, as John said, you see someone who's not eating, losing weight, or failing to gain weight for psychological reasons. That's a referral to us. Now, that could be an eating disorder, could be depression, could be anxiety, could be SD. If it is an eating disorder, we will see them. If it's any other psychological reason, generic CAMS will see them. Either way, you refer to the single point of access, and they will decipher that, and they pass on the referral to the right service. So don't worry too much about diagnostic criteria. Don't try to make a definitive diagnosis whether it is an eating disorder or whether it is any other psychological problem. And if you're in doubt, just speak to single point of access, and they will be able to direct you. In terms of what you need to do for your own assessment before you refer, first thing is to win the young person, is to put them at ease, is to reassure them about confidentiality, about being not judgmental and being respectful to them. You need to be very transparent with them about the limits of confidentiality and when you're going to be able to break that confidentiality based on risk. And involve parents wherever possible, because the main line of treatment is family-based therapy. So even if they're 15, 16, 17, even if they're gaining competence, try to motivate them to involve the parents as much as you can. Differential diagnosis, of course, is important if you can do that. And assess physical consequences and comorbidities. History taking is very important, as in any other problem. So mainly changes in their eating patterns, so things they used to eat and they stopped, things they used to like and they stopped eating. They started to develop food fear foods where they just wouldn't touch. If there's been any change to their exercise they're doing, any vomiting, especially if it's induced vomiting. So I'm sure you know about all this history taking. Assessmental state, again, briefly. Examine for any physiological consequences, any problems with their, whether they look malnourished, whether they've lost weight. It's very important that we get on the referral an accurate recent weight and height, because this helps us determine the urgency of the referral and how quickly we can see them. Check for muscle weakness, whether they can sit up from lying down or whether they can stand up from squat without using their hands. So
just check that you said to weigh it, you always told don't weigh the adolescent patient. Is that
we must have a weight for the referral. Well, if you're referring someone for a routine referral, it could take us 4 weeks to see them.
Yeah.
So in the meanwhile, if you can see them weekly and weigh them weekly, that's brilliant. Once we see them, we weigh them weekly during our course of intervention. There will be cases where it's too distressing for them. Some young people choose not to see their weight. Some young people, we choose not to weigh them. But generally speaking, it's very important that we have a baseline. We need to know how much they've lost over what sort of period of time. Because if someone's lost 2 kilos in the past, or 5 kilos in the past 3 months. It's not as urgent as someone who's lost 2 kilos in the last 2 weeks. So 1 kilo per week for 2 consecutive weeks is a big risk. And usually we would like to be treated in hospital rather than in the community. So having the correct, accurate weight and height actually are very important. Weigh them in very light clothes and take their height without their shoes. It's very important. It's not very helpful to weigh anorexic patients long term. So if they've been through treatment, if they've been, if they're especially adult anorexic patients, and we ask them not to weigh themselves at home. But for the purpose of making our minds up on how quickly we need to see them, it's quite that we have multi-height. So of course, investigations, again, at the point of referral, we need to have full blood picture, we need to have electrolytes. We actually have a standard letter that we send out to GPs as soon as we get a referral, asking them to do all these things. Because that's quite helpful for us. And we see the person on our first assessment day, and we aim to give them a diagnosis before they leave, and we aim to start our treatment, give them the first session of treatment on the same day as well. So if we have all this information beforehand, it's invaluable, rather than see them and then have to wait a week or so before we get the results. So again, refer early is very important. Consider the urgency. Refer for tell us whether you want them to be seen urgently or routine. We will still go over the information we have and decide, but it's very important that you alert us. So until we see them, advise them about the risk, advise regarding the regular eating. We would like them to eat 6 times a day. So 3 meals, 3 snacks, not go over 4 hours without having any food. So this is very important. And of course, follow up after we discharge. We always invite GPs to the CPA reviews, and especially not the CPA reviews, the discharge CPA. It's always helpful to have you there if you can at all. So
we have 2 minutes left.
Okay. So these are the criteria for the emergency kind of admissions. So if you think that they are 70% width for height, so they are 30% less than they should be. If there are significant like hypokalemia or hyponatremia or hypophosphatemia, dehydration, low glucose, posture drop. So if you take the blood pressure sitting down and then standing up and they drop more than 20 millimeter mercury, again that's a conversation to have with the pediatrician. So these are all red risk alerts that you have on the junior marzipan. Can you all see that? You'll have the presentation. It's a very helpful tool. So anything in that column is I refer to the pediatricians. Anything here is to us. So it could be even just a conversation with the pediatrician. So this is what John went on to talk about. So very quickly, just for your own interest, these are the refer sources, and this is the outcome on discharges. This is probably 1 year old, but I doubt it will be any different from the most recent one. So from a patient perspective, if we have to, I think it's about 2 minutes, the clip that the service user sent.
Do it and then wrap up. So.
Yeah. So this is Catherine, and we don't have the sound. It's not going to work. The gist of Catherine's message was that she went to see her GP, the first GP appointment. They were very reassuring. They said, you teenager, that's fine. All teenagers go through phases where they worry about their body and their weight. And they just said, you're fine. Mum wasn't very happy, so got another appointment a few weeks later. Same GP saw her, gave her more reassurance, and said, if you're worried, come back. Mum wasn't happy. Went again, saw a different GP. He sent out an urgent referral. She was seen within a week and started treatment. And she's now one of our expert patients. And her message was, don't take this lightly, and just bear in mind the importance of early referral and early treatment. So that was the main thing. So.
Thank you very much. So we don't have time for questions now, but we have 7 minutes for coffee break. And then I'll start my presentation, which will be shortened at 3:30. So help yourself for the coffee, and I think you can ask any question during the break.
Alison, do you want to?
Batteries and trains.
Not necessarily. Sometimes it's expectations.